Good morning. Welcome to what is going to be a really exciting hour. My name is Stephen Krein. I'm the CEO and co-founder, along with my business partner Unity, in an organization called StartUpHealth. For those of you who are in StartUpHealth, you know that you are part of a special community. We call it our global army of health transformers, the superheroes and the entrepreneurs and innovators and people who are building organizations that are solving the biggest health challenges of our time. I'm really excited to kick off this session this morning because it's really the culmination of a really important effort. And if you haven't picked up in your bag yet the issue number 10 of Startup Health magazine, what you're going to see on here is the cover boy, KP Yelpaala, who's going to be the host of the first panel. KP is a longtime health transformer. He's been in Startup Health as an entrepreneur for 4 years now, but over the last year, we have, with KP's help, organized a really important new moonshot that we announced last month at the Clinton Global Initiative called the Health Equity Moonshot. And for those of you who are familiar with Startup Health, we launched 12 years ago with a mission to improve the health and well-being of everyone in the world by inspiring and educating and investing in entrepreneurs who are transforming healthcare. And for the last 12 years, we have identified each year about 50 new entrepreneurs and companies to bring into Startup Health and join our global army. And so today, tomorrow, Wednesday, you'll have a chance to meet over 150 of the entrepreneurs that we've backed that are in Startup Health at the Startup Health Pavilion inside of the exhibit hall. And there's the Founding Funders program. I forget what it's called, Funding Founders right next to it. But we have programming that I hope you'll spend the time to get to know the entrepreneurs and the companies that what they're doing is carrying a very important message that is really about collaborating to achieve what we call health moonshots, these seemingly impossible goals that are only possible through collaboration. And we use the health moonshot framework as a metaphor for not the moon landing being this big goal, but the moon landing being a symbol of what happens when 400,000 people and 20,000 companies collaborate to achieve one thing. And the moonshots that we've built over the last decade and the moonshots that we've launched in the past year, the type 1 diabetes moonshot, the Alzheimer's moonshot, and now the health equity moonshot, are hopefully going to catalyze an important collaboration between all of the different stakeholders that are necessary to transform healthcare. Entrepreneurs, innovators, investors, philanthropists, the industry, and I mean payers and providers and pharma, who share a similar mindset, a common ambition, and the mutual urgency that we need to come together, to work together, to support the innovation that's going to actually transform the world. And for those of us who've been in Startup Health and around this community, it's palpable, the energy. We have this saying called batteries included versus batteries not included, meaning you give energy not just when you meet people, but in anything that you do. And there is nobody in Startup Health that has more energy than the person I'm about to introduce to host the first panel, KP Yelpaala, the Chief Impact Officer of our Health Equity Moonshot, and an incredible group of other panelists and people who are going to follow him all share this common belief that we need to do this together. It cannot happen alone, but we need your help, and I hope you'll join us on this journey. Please join me in welcoming cover boy, Startup Health, KP Yelpaala.
I'll do that. Thank you. No, I'm good. Good morning, everybody. How are we feeling? Doesn't feel like Monday, does it? Let's talk to someone. Starting a conference on Sunday is another thing. I'm so happy to be here with you guys. I want to talk a little bit about why we're launching the Health Equity Moonshot, what it's about. We've got some really great colleagues and friends, and we're going to have a conversation that I hope kind of sheds some kind of a different twist on this topic. I want to say that health equity really is about storytelling. right? Health equity is about bringing more stories into the fold in terms of what our health system needs to be about, right? And I think naturally when you meet health equity leaders, you realize we're all storytellers because there's a certain narrative in our health system today. And really, it's not a narrative that includes everybody, right? And so I think, what I'm super passionate about and what we're gonna talk about today with these three good friends of mine is the different work they're doing, their personal journeys, and also how it relates to the work and what needs to happen differently so that our healthcare system can serve everybody. So I'm gonna start by telling you guys briefly my story. So who am I? Right? You could read my bio, you see what I've done, but who am I? So KP Yelpaala, go by KP. Both my parents are from Ghana. They immigrated to the US in the 70s. I was born in Madison, Wisconsin. There's a joke that Africans find their way to the coldest places in the US. I don't know why. They don't end up in Florida or California first. But anyway, we moved to Northern California. I was always passionate about healthcare issues. And so my journey started in global health, right? And as I kind of have been on my personal journey, something happened this year that made me really want to double down. And that is that I'm a cancer survivor. I'm not afraid to share my age. I'm 42. And I found out in February this year that I had stage 2 moderately aggressive prostate cancer. Wow. How did it get caught? I was very fortunate to have a primary care doctor who really, I like to say my angels tapped him on the shoulder. Everything in my physical looked normal. I was healthy. I exercised. He said, what, have you had your PSA? I was like, no. And he's like, what, let's do it. Now, the standard would say that for me, because my father doesn't have prostate cancer, I don't have any known pre-existing conditions, I should have been screened at 50. Imagine that, stage 2 moderately aggressive cancer at 42. We know what situation I would have been in if I didn't get screened till 50, right? Prostate cancer kills black men at twice the rate of white men. Yet, the narrative around prostate cancer is that generally, it's supposed to be something that's indolent. In other words, every man is supposed to get prostate cancer. And usually, for people that get prostate cancer, it's not aggressive, right? Usually, for someone that gets prostate cancer, something else may kill you later in life, not prostate cancer. Yet here I am, right? So that's my story. That's what health equity is about, right? And so I want to bring on to the stage my colleagues. Please come on up. Yeah, you guys can sit. Oh, yeah, she's looking for some walk-on music. Sorry, I don't have that for you today. I've got three really wonderful friends and colleagues, Dr. Lauren Powell, Colby, Takeda, Jessica Thurmond. They're going to bring different lenses to this topic. And very much like how I started, I'm going to start by them telling you a bit about themselves and their why. And then we're going to get into the work they do, and I'm sure we're going to have a nice conversation. So Lauren, I'd like you to kick us off. Tell us a bit about who you are and your why.
Yeah, well, good morning. Oh, good morning. Thank you. Thank you. My name is Dr. Lauren Powell. I have been working on health equity for quite some time. I first need to start by saying I work for a pharmaceutical company, but I am not representing them today. I think my passion for health equity started when I was young. I actually didn't know what to call it. Several experiences. I had severe asthma as a child, and I was always in and out of the doctor. And it was never really fully controlled, and I couldn't really understand why. And come to find out, it was really about like the social determinants of health. It was more about like the atmosphere at home and things like that. Fast forward to college, I went to school at Xavier University of Louisiana in New Orleans, and Hurricane Katrina happened my senior year of college. And so I went from being in this vibrant city of New Orleans to this really broken infrastructure and seeing and experiencing what I would soon learn is called the social determinants of health, up close and personal, and not really knowing how to classify that, but experiencing it and having all these questions like, why is it like this? Why are we having so many problems here? And why are so many people okay with that? And then I think in grad school is when everything really kind of came together for me. Throughout my time in grad school, it was a rather short-ish program. I did my PhD in clinical and population health research with a concentration on racial and ethnic health disparities. So I would be in class learning about social determinants of health, learning about health inequities, and then experiencing that in my own personal life where I lost so many family members in a very short period of time, around 20 family members actually, to chronic illnesses, to things that could have been controlled, to things that could have been addressed had there not been racism in the healthcare system. And it pains me so much to have experienced that myself, but to know that my family is more of the norm and not the exception in communities of color. And so that really, it's both sort of the thorn in my side and also the fuel to my fire. So I will stop there for the moment.
Thank you so much, Lauren. Colby, on to you.
Yeah, thanks. Hey everyone, my name is Colby Takeda. I'm a former senior living administrator, so I used to run senior care facilities. And growing up, my grandparents are obviously a big part of my life. Seeing them age through the process and get the support from their family and their friends has been very fortunate for them. And when I worked in senior living, it was a very different experience, right? Seeing different grandparents, not being able to explore and understand their different care options, seeing families being torn apart because of the caregiving burden of, or the needs of older adults, and seeing them struggle with finding good housing and not being able to afford different care settings. And in the setting I was working in, we charged $8,000 to $10,000 a month, and I had to often turn people away because they couldn't afford to live in that setting. Very different contrast. I then went to work for the Blue Zones Project, and looking at how the Blue Zones, like the places in which people live, work, play, pray, learn, really makes a difference. And being able to see how food access and health equity and transportation options and living in a food desert or having family and friends or having the social support network is really impactful. And it was such a big contrast to the setting I was working in when we were taking care of people that could afford $10,000 a month. So that was my first, interesting look into what the differences in the healthcare system are, and different inequities for different people of different backgrounds, and based on where you live, the family which supported you made a really difference in my life. And so now I take that to my work today, and I'm excited to talk more about that later. But yeah, thanks.
Great. Thank you so much, Colby.
Yeah, thanks so much. My name is Jessica Thurmond. I am the co-founder of Athelo Health. So I think anytime we talk about health equity, it starts with us as people. So for me, I identify as a formerly homeless female founder. My pronouns are she, her. I am a proud descendant of the Wapton Oyate Sioux tribe, and I have a wife who is an educator, and I live in the South. So for me, the why behind creating Athelo, in part, comes from me having lost my mom in the 90s when she was young. She had a breast cancer diagnosis and came from a disadvantaged background. The other part of that is having worked in the cancer care space and biopharmaceutical for over 10 years, I see no shortage of money going into the life-saving therapeutics that we're so grateful to have, but I don't see enough of the patient experience moving forward in the way that we handle underrepresented populations and disadvantaged individuals, and that's what brings me here today, and we're excited to talk more.
Thank you, Jessica. So I want to start with definitions and kind of how the landscape for health equity looks today. A lot of people are talking about health equity. We're using these two words to describe something that has existed for decades, right? And even centuries. We want to go back far enough, right? So I think oftentimes we're having this conversation like it's new, but really we're just using these words to describe something that has been persistent, pervasive, deep, and really troubling for a lot of people in our society generationally. So what I would like my good friend Lauren to do is first just frame how do you see what health equity is? And then just what's your observation of the state of play today?
Ooh, we could talk about that for the rest of the day. So I should first say in my capacity as president and CEO of the Equitist, this is what I do all the time. So health equity, if I were to put it into layman's terms, it is helping everyone live their best life. Right? So that means removing the barriers, removing the systems of oppression, removing all the impediments that keep us all from being able to live our best and most well life. I would caution you to recognize that equality is not the same as equity. So sometimes they're used interchangeably, but they are not the same word. They do not have the same meaning, and they don't have the same application either. So equality is giving everyone the same thing, but equity is actually tailoring resources. So that means some communities will get more resources than others, and that's actually okay. That's literally the definition of equity. I think what I'm seeing is that there are a lot of people who are very comfortable using the word health equity, who like to toss a hashtag in front of it, put it in a proposal, put it in an RFP, but you really don't quite understand what health equity actually means and what it takes, the sacrifice it takes, the innovation and the time it takes to actually drive health equity forward. And I think, the state of where we are, I'm so excited that there's so much spotlight on health equity, and I'm so excited that there's so much energy around health equity. However, I don't want to overlook the fact that there are people who have been doing health equity work since before it was a term, since before it was popular, since before it went viral, and we should also be looking to their expertise on how we continue to move forward.
Great, thank you for that. I want to build on this. So for people in this room who are, I know we've got a room of people who are action-oriented. If you were going to give people a few tips of how they might start to approach thinking about health equity and their various roles as healthcare leaders, and they want to operate with intention, what would be maybe a few tips you would give them in how to start or how to go about the work?
Yeah, well, I think we prioritize what we put money behind. So it is like really great timing to have someone who is leading health equity work on your team. If you don't have the budget for that, I think that you can start by thinking about who your priority population is and making sure that someone from that community is actually represented in your decision making, not after you've made the decision and you're reporting it out to them, but that they're actually at the table giving you their insight, giving you their lived experience, and helping to create the solution, co-create the solution with you. I would say second, really thinking about how you distribute your resources. So, health equity, focusing on health equity requires us to take a little bit more time. So thinking about time as an actual resource and as a way to actually help mold and shape the products that you're creating can still happen quickly but effectively, in making sure that you are incorporating the voices of people who will be impacted the most.
Great, those are some great tips. Thank you so much. I want to move to narrative a bit. So last week I was with my son. I take him to the barber. I no longer can go to the barber, so I take my son. It's, we love the barber shop. This guy DeLon has been, my barber, now my son's. One of the things I've been doing this year is talking to black men about prostate cancer. And I'm happy to say that at least 50 of my friends have gotten screened and asked for the screening. Most of them around my age were not offered screening. So I was talking to DeLon last week, and we were talking about prostate cancer, and I was talking to him about getting screened. And he said, KP, the issue is, I don't have a provider that I trust, and I don't know how to find one. That really made me sit. I'm still sitting with that, right? Because here I am advocating to him, and he wants to take the action. And he's like, I don't have a provider that I trust, and I don't know how to find one. Jessica, I would really like for you to share, if you'd be willing, a little bit about your mom's cancer journey and what that looked like and how that impacts you in your work today.
Yeah, of course. So in the late 90s, my mom found a lump in her breast. She was in her 30s, and as many people know, you typically don't start getting breast cancer screenings until you're 40 years old. So she went to the doctor and she said, I have this lump, something's wrong, and I don't know what to do. And they said, well, we typically don't do mammograms, but I guess, we'll see if we can get any approval for you to come in and get it done. So the results from that mammogram came back. They said, you're all clear, nothing wrong, you're fine. 6 to 8 weeks later, the lump in my mom's breast had gone from the size of a pea to the size of a golf ball. She called the doctor again and said, something's wrong. I know the mammogram came back clear. And they said, it's probably a swollen lymph node, and they made her feel really small. I'm amazed she continued to push and advocate for herself, because my mom didn't grow up with access to a lot of health care, and she didn't have an education. So eventually they said, okay, we'll do a breast MRI. And the results came back and they said, whoops. And she had a breast biopsy done at that point, and they found that my mom had aggressive inflammatory breast cancer. 9 months later, it had gone everywhere but her brain, and she died at the age of 39. So for me, this has been a massive driving force behind my career. Not only from the prospect of me as a woman, anytime we go to the doctor, and as whether you're a minority from a different socioeconomic status, you're often met with skepticism. Are you pill seeking? Are you being hysterical or imagining things? And unfortunately, we still see that today, even in different populations and people who do have the finances and means. And so what we see with Athelo is trying to really put the patient at the center. And some of the challenges that I see as a founder are convincing investors that you can put health equity and patients at the center of a product and still align all the stakeholders around it, from biopharma to payers and providers. Because at the end of the day, nobody knows your body better than you do. Nobody is going to advocate harder and better for your health care than you will. So I think it's our job as a medical community to not only respect that, but embrace it by empowering patients to be active consumers of their data, to be able to guide that whole patient process, and not only as patients, but as people, because we need to really be addressing things in terms of whole patient care, and that's one of our goals with Athelo.
Thank you so much for sharing that. I really, really appreciate it. And I want to honor her for sharing this, right? Because, yeah, this is what health equity is about, right? So it's about people's lives. It's about more time, right? So I want to dig in on this. There's a lot of conversation about business model, right? A lot of our talk about health innovation is repeatability, scalability, right? But every life matters. And the business models for health equity, they need to take into consideration these unique lived experiences. And that's not a widget, right? It's not a widget. So I urge everyone here that we have to think hard about what the new models will be and to honor the stories of the entrepreneurs that come and put their heart into this work and then get told, well, your ARR isn't this, your model's not repeatable, scalable, whatever. Right? Her mom could have had more time, right? Equity, that's really what it's about. People are dying unnecessarily. So I want to kind of talk about business model for a second, because this is a little bit of the elephant in the room with health equity. And Colby, like with your model, like really using community health workers and people that have that trust and interface, I know there are kind of both opportunities and challenges in how you build the business models in a way that's convincing and where you can kind of prove that scalability, but also show the impact. So I'd love for you to talk a bit about your work and kind of how you approach that.
Yeah, thanks a lot. So I'm the co-founder and CEO of Pear Suite. We're building software for care navigation, specifically for community health workers to address the social determinants of health for older adults. And we recognized during the pandemic, the biggest challenge was getting to work with older adults, specifically from minority populations, where language was a barrier, access to care was a barrier, people that are socially isolated was a barrier. And we found that when you build relationships, when you build trust and take the time to get to know people, their background, their history, their stories, you can really help drive action. And not just taking action, but actually maintaining that action. And so we've used this model of communication by phone to reach out to older adults who are hard to reach, from minority populations, empowering people that have language competencies or understand the culture, finding people that are trained, not necessarily as social workers, case managers, but were trained from the community. They worked at community health centers. One of our best users of our platform is a parking lot attendant who knows everyone at the community center because he has a relationship and knows the people and is able to connect with them and help them toward annual wellness visits, for their classes, for fitness, for getting them on their SNAP benefits. And so, yeah, the community health workers are a great tool. I think it's all about how do we align payment models with this workforce. It's really economical, scalable workforce, but right now, a lot of organizations aren't paying the right wages that they should be earning. We see organizations, really large ones, paying $20,000, $30,000 a year for these community health workers. But if we can align the payment models with the data that the health plans and payers need, we can help them get higher reimbursements and then lead to higher wages. What's really exciting is about 23 states now actually will start reimbursing community health workers through Medicaid programs. So we're seeing innovative approaches to reimbursement. We're also seeing a lot of organizations using community health workers for multiple things, supporting the doctor or physician that's providing care and have that team-based care model, so it actually allows them to expand their revenue sources. And we're also seeing a lot of community health workers supporting with saving on costs and increasing bonuses with the HEDIS and STARS. And so definitely if we can tie payment models to the workers and then giving people the power and then with data, we can see a lot more reimbursements and allow them to get higher wages.
That's amazing. Thanks so much for sharing that. And I think that's another issue that we'll see a lot more traction with, I think, is about data, right? You can't sustainably change what you can't measure. And even if we look at value-based payments and really encouraging people to reduce disparities, we have a big data problem around race, ethnicity, language data, gender data, things that help so that you can kind of bolster and scale the model, but you've been building a great foundation. Unfortunately, we're out of time. I know I could be here with my friends for another 20, very easily having this conversation and them sharing their wisdom, but I just want to thank our panelists. Let's give them a hand. And these are the types of people and individuals that we really like to work with, and when we think about our health equity moonshot, these folks are really paving the way. So I really appreciate you guys. Thank you.
Thank you.